Hello, everyone. Thank you very much for joining us today. I'm Dr. Greg Hobbs. I am the co-founder and chief medical officer for Milagro, a innovative platform that fully automates or provides autonomous coding for surgical procedures. And I am very excited today to be joined by Diane Lerch, who is the Senior Director of Coding and CDI at Tampa General Health System. Diane, would you introduce yourself, please?
Sure. Thank you, Greg. I have been over the coding and CDI for Tampa General now in their health system for a little over 11 years. My background is in health information management. We have a team of approximately about 50 coders and about 45 CDIs that help with all of the hospital-based coding. And if you're not familiar with Tampa General, we are one of the largest academic medical centers. We are a safety net, level 1 trauma, do quite a bit of transplants and have a NICU and burn center. So we have some of the sickest patient population that we serve here. And we're always striving to be innovative. And that's something that you'll learn a little bit more about that we've been able to do in partnership with Milagro. So I'm happy to be here today.
Thanks, Diane. Talk a little bit more about the complexity of Tampa General in terms of not just what you have in the hospital, but the physician practice, the outpatient settings that you have as well.
We have really grown that we have, and I'm trying to keep track of the count, but I think we are over 150 different locations between networks of clinics, urgent cares. We've spread out across Florida. We're not just in the Tampa Bay area. And we also additionally, in addition to the academic medical center, have 3 community hospitals that are located up in the Citrus Hernando area that serve the community in those areas too.
Wow. So it's a major health system.
Yes.
And you won't say it, but I will. Always rated one of the top in the country. And
yes.
It's we're honored to be working with you. And so there may be people on who aren't very familiar with Milagro. So I will give just a very short overview of what we do. We're a back-end data abstraction platform. We fully integrate with whatever EHR, in the case of Tampa General, Epic, and automatically capture and process the data that we need to then fully code surgical cases. And we code both the professional and the facility. We do all of the coding that is required for billing for that particular case. So not just the CPT code or the ICD, but modifiers, HCPCS, whatever is appropriate for that case. Our initial focus is on outpatient surgical coding, but we are expanding to inpatient surgery and to ambulatory settings for E&M as well. So that is us. So Diane, can you talk a little bit about the challenges that health systems like Tampa General are currently facing with coding? The workforce challenges, the problems with denials, decreasing reimbursement. It's a tough world right now.
It is definitely a tough world. And, one of the struggles that I think we've had that's not unique just to Tampa General is finding qualified coders that have the right experience. In addition to that, one of the things that came up that we've had as a reoccurring issue related to denials was related to the lack of appropriate authorization. And, we would get the authorization, but unfortunately, sometimes when they get into the surgical, they find that there's something else that needed to be done, or something that was unexpected. And so they end up doing something that's a little bit different from what was originally authorized. And because that authorization was required, it would often result in a denial And unfortunately, those denials usually result in no payment or a very extensive appeal process.
Yeah, and so these are not cases where the pre-authorization was done inappropriately. These are cases that out of clinical necessity, the surgeon did something different than what they initially thought they would do. And so then you have the payer rules that not only deny those, but in some percentage of cases will give you an opportunity for reauthorization, but they very cleverly limit that to a time that you can't really get the coding done and deal with that.
Right. It's not an unusual instance to see that a surgeon may decide that there's something more that needs to be done that wasn't really originally planned. And really, it's what's in the best patient's interest for quality of care and their safety to do what's needed. And so, it's unfortunate, but with the authorization requirement, we were finding that we were receiving a lot of denials related to that particular issue.
So can you talk a little bit? So this is something that we have worked together to solve, a problem that we've worked together to solve, because Milagro has the ability to code these cases immediately post-op. As soon as the initial post-operative note is done, we may not have all the data to fully code the case, but we almost always have enough to identify the CPT code and modifiers, and then identify if that's different than what was pre-authorized. So how has that worked at Tampa General? How have you guys been able to use that?
Well, one of the strategies that we did in partnering with you, that my revenue cycle leadership had said, hey, we've got to figure out something. How do we identify that, what was authorized wasn't, got changed? And we talked about, can we put a coder in there? And it really didn't make sense to put a coder in the OR. Most of our coders are remote. And it was a constant struggle. And one of the things that was really appealing when we were looking at the innovation that Milagro had was the ability to do that real time. Because we had been looking at other autonomous coding solutions, and unfortunately, they didn't have some of that same functionality that we were looking for the denials mitigation. And what's been really a nice synergy and getting that real time is that Milagro does have that ability to go ahead and do the real time coding. And then any of those that they do, they compare it to what our schedulers have authorized. And if there is a mismatch, then they send those to my coding team to review. And my coding team immediately validates those. And we find that Milagro has a very high accuracy rate related to that. I want to say at least 99% of the time they're accurate. And then we're able to hand those off to our scheduling team same day so that they are able to go out and mitigate that denial by going out and getting an updated authorization. Because the key was the timing. A lot of the insurance companies said, you can get an updated auth, but you only have 24 to 48 hours. And even your best coding team today cannot get those things coded within that time frame. So we would often find out, but it was too late. The time frame had passed to get that updated auth.
And then you're working the denial and hoping at some point that you get some reimbursement.
Exactly.
Yeah. And correct me if I'm wrong, but I believe that Tampa General is getting successful reauthorization and collecting on about 95% of the cases that Milagro automatically identifies and pushes back to the schedulers.
That is correct. It really takes that off the table for the, insurance to use that as the denial reason, which is nice because it's a very efficient workflow that helps us mitigate that problem. And it was a significant problem, with our outpatient surgeries. A common one that would come up that I think people could relate to is how many times a patient might come in for a screening colonoscopy and then it converts to something diagnostic. And that's a frequent occurrence, but in some instances, it would really be a challenge with certain payers if you didn't get that updated auth, within that time frame. And now we have a very efficient workflow a partnership with Milagro and mitigating that.
So that's been a good thing. Getting the cash back in faster. So and avoiding the manpower that's involved in. It's not just not getting paid or the delay in payment, but people have to actually do that work. And so these manpower issues, I think, are critical issues for revenue cycle teams, anywhere in the country that we've spoken with. Our data shows that maybe 30% of all outpatient surgical cases actually fall into this area of a mismatch, pre-authorization mismatch, and about 10% of overall cases, of all outpatient cases, the payer both requires and allows reauthorization if you can do it within 24, 48 hours. So
correct.
It ends up being a big dollar amount.
Yeah, and it was nice because we were able to develop a process and a workflow that made sure we identified those particular payers so that we could take that action where we do have that ability. And even a higher prioritization for the payers that only allow 24 hours versus others that might give you 48 hours or a little bit more time to respond, so that we could really triage cases the way they needed to be handled.
Yeah, and we work together to get those payer rules built into the Milagro platform, so that's not manual work that has to be done. Somebody doesn't have to figure that out. The system knows that, and so we're only sending cases back to the schedulers that both require and allow the reauthorization. So let's talk about inpatient coding. Is that, that's a beast, right?
Yes, that is a beast in and of its own right.
Yeah. So talk about the differences, the challenges for inpatient coding. And you don't even have coding assistance for most of those cases, do you?
No, we don't. And that's something that I know that we are starting to build, some of those particular rules so that we can start taking that on. I mean, one of the things that was really evident to us from doing the denials mitigation was the reliability of Milagro on the accuracy for the CPTs. So one of the things that we're currently doing is leveraging the system to do autonomous coding for outpatient surgeries. And what Greg had alluded to earlier is that we're looking at how we could leverage this technology to help us in the inpatient setting. It may not be for all of our cases at Tampa General, but we do have quite a few cases that may not have as high of complexity that we could leverage the inpatient solution to definitely help us and free up coders to do other things and upskill them.
Yeah, so that would be things like scheduled surgical cases, L&D cases, those sort of things, right?
Yes.
Not. So I'm an ER doctor. I didn't say that up front, but for those of you who don't know me, I still practice emergency medicine. So these are not the septic cases that I'm admitting from the ER to the ICU. These are the scheduled colon resections, gallbladders, and maybe even some of the less complicated emergency surgeries like an appendectomy or something less complicated.
And I think you alluded to it earlier, just having an opportunity with the obstetrics, mommy baby, as I usually call it, and being able to leverage the inpatient coding, there in that particular setting also. Yeah.
So if you were able to get that, just these kind of cases autonomously coded at the same level of accuracy that we're doing in the outpatient setting, where we're coding across your surgical specialties at above 95% accuracy, measured against a 0 to 1, right? Either all the codes are right or it's wrong, as opposed to sort of the scale that coders generally get measured against, right? You get points for getting this right and points for getting this right, and if you miss that, you get a little counted off. But you either get 100 or you get a 0. Just from a manpower and the ability to identify and hire and retain the skills that you need in those type of coders. I've talked to health systems across the country that tell me they really are struggling to find these coders.
It definitely is a challenge, and it's not something that's new, but it's just a real struggle. And then, as the regulations and just the environment we're in with denials and those types of things, it really takes that higher skill set to try to help, manage those particular areas and be able to respond the way we need to.
Yeah. So we've got a few more minutes. I want to sort of jump into the other part of your job, the CDI. So I have, in various roles for longer than I will say on air, been trying to get doctors to do things different and better. And it's a frustrating group of people to work with. How can real-time coding, real-time evaluation of physician documentation help in CDI? Do you see any potential? And this is something that I don't think you and I have ever actually talked about together.
No, we haven't. So we're gonna have to think about that a little bit.
Yeah. So it's an area of interest. And I get asked this a lot. Could you use Milagro to help with CDI? And one of the things we're able to do is, we can tell when a case, we believe that that they did procedure X, but they documented procedure R, and there's a bunch of dollars on the table because of that. And being able to identify that real time and provide that feedback to doctors. I've been convinced for a long time that telling me what I did wrong 3 months ago doesn't change my behavior very well, right? But if you tell me, you know what, you didn't do this. If this is the procedure you really did, you need to add this because you keep complaining that you think you're under reimbursed for your cases, but here's why.
Right. Well, and any tools that we can give to a provider to help them with their documentation and maybe take the burden off, or, to be able to target where we need to, and giving that real time type of notification, I think is going to be more beneficial, to your point, than coming back and pointing out a case from 3 months ago that basically is out of sight, out of mind. I think it's much more effective. And that's the thing that we've really found, in the beginning of our partnership, with starting with denials mitigation and then moving into full autonomous coding, is just, it's that ability to do that real-time instant, results to give us what's going on, or to take action if we're trying to address a particular issue or identify something that we're trying to work on.
Yeah, great. I couldn't agree more. So we're almost out of time. I will give you the floor to say anything else that you would like to add today.
Well, I think we've probably covered most of everything, but I would say, for leaders that are out there like myself, I know a lot are looking for an autonomous solution, or a way to be able to integrate the latest in technology and be innovative in your department. That, this is something that we've been able to do in our partnership with Milagro, and it's kind of taken us not only in what you might traditionally think of as an autonomous coding system, but having that real-time instant feedback really helps you with partnering with other areas in your rev cycle to mitigate denials and other opportunities that you can explore that I haven't seen. And so that's one of the things that, I would say as a takeaway for any leader out there that's trying to consider a solution.
Well, thank you very much for that. And thank you, Diane, for making the time and joining me today. This has been great. Really enjoyed it. And I look forward to seeing you soon.
Thank you. I really enjoyed it. Bye-bye.
All right. And for those of you who joined us, thank you very much. And we greatly appreciate it. Everyone have a great day.
Yes. Thank you. Bye-bye.